So in the next 15-20 minutes, I am going to talk about efficacy and safety of intravenous belimumab in patients with active lupus nephritis, the BLISS-LN trial. Was an ambitious trial. It took about 7 years to develop, and we are really glad that it is a successful trial, and it was the first biologic therapy to be licensed for lupus nephritis. Just to declare my conflict of interest, as you know, I worked over the last couple of years with GSK. As you know, the belimumab or Benlysta is not a new drug. It has been a license for lupus for more than 10 years now, when BLISS-L52 and BLISS-76 were both a successful trial, and the FDA and EMA licensed the drug in 2011. Please note, in these trials, which led to the licensing of the drug in 2011, we excluded severe active lupus nephritis. So how we define severe active lupus nephritis in these trials? Those with heavy proteinuria, more than 6 grams in 24 hours, those with renal impairment with serum creatinine more than 2.5 milligram per deciliter, and those with severe active lupus nephritis requiring, for example, dialysis, and those requiring high dose of steroids to control the disease. This is how we defined severe lupus nephritis. That doesn't mean if you have milder form of lupus nephritis, you were not able to participate in these trials. And in fact, if you can see from the slide, 267 patients, which is 16% of the total number of patients recruited for these studies, in fact, have lupus nephritis. And when you looked at the pooled data and post-hoc analysis, was interesting to note that this subgroup of patients, there is signal to suggest perhaps the drug could be effective in lupus nephritis. And this is where the drug company decided to gamble and to establish a randomized controlled trial, which I'm going to share with you the result of this trial in the next few minutes. This was an ambitious trial, and there is several characteristics special about the design of this trial. First of all, note the number of patients. In this trial, they recruited 448 biopsy-proven lupus nephritis, class 3, class 4, class 5, or combination of these. That makes this trial one of the largest ever done in lupus nephritis. Second observation in the design of the study is that duration of the study. The primary endpoint was assessed at 2 years, 104 weeks, not after 6 months, not after 1 year, after 2 years, which is unique again in the study. So the patients were randomized to 1-to-1 to take either belimumab intravenously, 10 milligram per kilo, which is the licensed dose, plus standard of care, or standard of care plus placebo. And the standard of care here was left to the decision of the treating physician, whether the Eurolupus study giving cyclophosphamide at 500 milligrams every 2 weeks for 3 months, and then maintenance azathioprine, or you start immediately with mycophenolate mofetil and maintained with mycophenolate mofetil. And that was left totally to the treating physician. Another important thing in this trial, remember goes back, the design of the study, to 2012. It was at that era we start thinking that steroids could be useful, but at the same time can make a lot of damage. So we wanted to save steroids. And in the design of this study, it was mandatory by design that all patients participating in this trial should have their steroid reduced to 10 milligrams or below. If they were taking more than 10 milligrams by 24 weeks, then this patient could be considered as treatment failure. At the end of the study, which is 104 weeks, those patients who completed to 104 weeks, they were invited for open label extension for another 6 months to gather more information about safety data, really. And this is the way how we tapered steroids by week 24. Did we allow in the study pulse steroids? Of course, we allowed pulse steroids to between 1 to 3 pulses maximum, and the maximum oral steroids was allowed to 60 milligrams or below, which is about half milligrams or 1 milligram per kilo. The oral corticosteroids have to be tapered, and we suggested this tapering regime, but obviously you can follow the regime you want, but week 24, all patients recruited in the study should have 10 milligram or below, otherwise will be considered as treatment failure. The primary and secondary endpoint of the study. The primary endpoint of the study was PAIR at 104 weeks. What's PAIR? Is a primary efficacy renal response stand for. And the composite score, which is you have to fulfill these 3 criteria to be considered as PAIR responders at week 104. It has to be eGFR more than 60 milliliter per minute is to see the renal function is maintained, and no more than 20% below the pre-flare value. UPCR, which is urine protein creatinine ratio 0.7 or below, and the patient is not considered a treatment failure. You didn't need during the 2 years of follow-up to increase steroids or add other immunosuppressive drug to control the disease. And to be considered a responder, you have to fulfill these 3 criteria. Major secondary endpoint in this trial is complete renal response at 104 weeks. A slightly more strict criteria, again, a composite score requiring eGFR is no more than 10% below the pre-flare value. UPCR less than 0.5. It was before 0.7. Here we have to accept is more strict criteria 0.5, and the patient is not considered as treatment failure. We also wanted to see at midterm of the study whether the PAIR at week 52 is achieved as well. And the most important thing from clinical point of view is time to death or renal related event. And we also looked at ordinal renal response, which is complete, partial, and no response at week 104 as secondary endpoint. At the end of the study, we had a balanced number of patients in belimumab and balanced number of patients in placebo, 223 patients in each group. As you can see, as you can expect, 88% of the patients were female. The mean age was 33 years. Class 3 or class 4 lupus nephritis were the majority of patients, about 58% of the patients. Class 3 plus 5 or class 4 plus 5 were 26% of the patient. And pure class 5 lupus nephritis was 16% of the patient, distributed equally between the 2 groups. And then please note that we left the induction, whether cyclophosphamide or mycophenolate mofetil, at the discretion of physician. And at the end of the study, we noticed that 1/4 of the patient were treated with cyclophosphamide and maintained with azathioprine, and 3/4 of the patient received mycophenolate mofetil during the induction and maintained with mycophenolate during the maintenance therapy. So 1/4 with cyclophosphamide and 3/4 with MMF. Here is the primary endpoint of the study. In orange is the belimumab group, and in purple the placebo plus standard of care. And as you can see, 43% in belimumab plus standard of care versus 32% in the placebo plus standard of care, with an odd ratio in favor of belimumab of 1.55. What's the meaning odd ratio 1.55? That's mean the chance of achieving PAIR at 104 weeks was 55% more if the patient were treated with belimumab. But most importantly than that, you have to look at visit per visit. If we look all visits throughout the trial, and you can notice that belimumab separation started around 20 weeks, and the separation opened at 24 weeks in favor of belimumab. So starting at week 24, there were more responders at each visit in the intravenous belimumab group compared with the placebo group. There was a 46% increased chance at any time of starting a PAIR that would be maintained to week 104 in the intravenous belimumab group. Is not only achieving PAIR, is maintaining the response throughout the study. Major secondary endpoint, again, In the purple is the placebo arm of the study, and the orange is the belimumab, 30% in favor of belimumab compared to 20% in the placebo arm of the study, with an odds ratio 1.74%. Again, the chance of achieving complete renal response was 74% more if the patient received belimumab plus standard of care. Similar to what you saw in the previous slide, that's to see visit per visit throughout the study until week 104, there was a 58% increased chance at any time of starting complete renal response that will be maintained to week 104 in the intravenous belimumab group compared to placebo. As I told you, we also wanted to see at midterm of the study at 1 year if there is any differences between belimumab and placebo, and again 46.6 in favor of belimumab compared to 35.4% for placebo, with an odds ratio 1.59 in favor of belimumab. This is, from clinical point of view, is the most important slide, I think, of my presentation, is how many patients died during the trial. How many patients have end-stage renal disease? How many patients have deterioration of their renal function? As you can see clearly in the slide, the risk of renal-related events or death at any time up to week 104 was 49% less in the intravenous belimumab group compared with the placebo group. And this is extremely important from clinical point of view. Again, every time you have flare in the kidney, you lose function of that kidney. Every time you have flare of the kidney, you lose 15 years of the life of that kidney. And that's important to show any drugs they use that you can prevent flares. And you can see in our trial, patient in the intravenous belimumab had 43% lower risk of experiencing a severe flare at any time compared with patient in the placebo group. And this is, again, from clinical point of view, is quite relevant. Another important slide is to see the function, measuring the slope of eGFR over the trial. And as you can see in purple, again, the placebo arm of the study, and the orange is the belimumab treated group. And as you see clearly, that eGFR values were numerically greater in the intravenous belimumab group compared with the placebo group. So to maintain renal function, it's important to see the slope. And as you can see, the slope is maintained throughout the trial, and slight decline in those patients who receive placebo plus standard of care. Steroids. It was not mandatory after 24 weeks of the study, when we reached 10 milligrams, to carry on reducing steroids. But again, we left it to the discretion of the physician to reduce steroids during the trial. And you can observe that they managed to reduce to less than 5 milligrams a day and less than 7.5 milligrams a day. That more patients treated with belimumab managed to do this than those patients treated with placebo plus standard of care. And final slide, obviously, it's about safety. Did we observe any more safety signals compared to what we know about belimumab that we have been using for now 10 years? Interestingly, there is no new signals by adding belimumab to standard of care in the treatment of lupus nephritis. We have an adverse event occurring in both groups equally, about 95% in both groups. Adverse event resulting in discontinuation of treatment was 13%, similar in both groups. We have 11 deaths during this study, 5 in the placebo and 6 in the belimumab group. When we look at adverse event of special interest, like malignancy, infection, herpes zoster, TB, sepsis, there is no difference between the two groups. And when you look at depression, suicidal ideation, suicidal thoughts, there is no difference between the two groups. This is the first time we used belimumab in combination with cyclophosphamide. We were worried about this combination, but in fact, it showed that the combination with cyclophosphamide, mycophenolate mofetil, for long time, there is no increase incidence of these adverse events. And the adverse events we have seen over the years keep the same, and there is no difference between the two groups. I'm happy to take any question you might have after my talk.